So,
Recording in progress.
so good afternoon to all the participants and from various institutes and on the state hospital officers and other people who have logged in. I'd welcome you once again to the Center of Excellence program being conducted jointly by the All Indian Institute of Medical Sciences, New Delhi, and the Ministry of Health and Family Welfare on monkeypox management. This is the third of the series of fourth webinars that we've had, trying to give a broad overview of monkeypox in terms of the global burden, the investigations, and today we're talking on a very important area, the clinical presentation and management. As you know, monkeypox is something that is a cause of global concern. Number of cases are very few, and therefore, although we need to have a high index of suspicion, we must remember that there is a large differential diagnosis, and we should not jump to a conclusion that every case who presents with a fever and rash is monkeypox. That may not be the correct approach. But at the same time, if the index of suspicion is high, if you have other features like we had mentioned yesterday of lymph nodes or the rash on the palms and soles, or a history of contact, then it's very important to really look at investigation and also try and see what we can do. Today, we'll try and give you an overview of the clinical presentation and the management. The management tends to be predominantly supportive as per the ministry's guideline. There are some medications which are available, but they are not, which are prescribed, but which are not easily available. And therefore, it's good to know about them. But currently, the treatment strategy is predominantly supportive. To really give us a more detail as far as this is concerned, we have Professor Naveet, who's Professor and Head Department of Medicine, who will be talking on clinical presentation and management. And I have with him, we have the other panelist, Professor Kaushal Verma, who is the Head Department of Dermatology, Professor Anant Mohan from the Head Department of Pulmonary Medicine. And before we take your questions, I'll ask Professor Naveet to give an overview as far as clinical presentation and management is concerned. Just one final thing, any questions that you have, please put them on the chat box and we'll take them later on. Over to you, Dr. Vig.
Thank you, Professor Guleria. So you had two webinars on global epidemiology, and then we had a webinar on diagnosis. So what are the clinical features, and why are we discussing monkeypox, and how are we going to manage it? If you ask me today, what are the clinical features? If any patient who comes with a skin rash and he has got an epidemiological risk, I would say that he might be having monkeypox, but we have to know the other differential diagnosis. And then what is the management? The management is supportive. So rash with epidemiological features and management is supportive. So is that enough? So if you think about monkeypox, why it has been declared, as emergency of international concern by WHO, why there is so much of panic? Is it like HIV? Is it like COVID? Or is it like chickenpox? What is the R naught for monkeypox? So we'll discuss, we have to understand all these features to go to the clinical features and management. And so monkeypox is the orthopox virus. Are they new or they are old? And it's a DNA virus. Can it cause a pandemic like RNA virus? We had many pandemics by RNA virus, but it is a DNA virus. Can it cause a pandemic? How to differentiate clinically from chickenpox will always remain. It's sometimes it's difficult, but it can be easy, but experience is required. So our dermatology is going to be fresh in next few, because it is going to remain endemic. It is not going to go away. It will remain there like HIV, and how to differentiate between different cutaneous lesions, and then we'll come to the management. So if we look at about monkeypox, we know that it came first lab outbreak in Denmark, then it came from Africa. But most important is how we differentiate it from some other viral illnesses like HIV. It is a self-limiting illness. So most important message which I would like to give is that it is a self-limiting illness. And you see 32,000 patients have been there, but mortality is only 12. So mortality is less than 0.04%. So we should not create a panic about it. The way it has been created, probably it has been created to make sure that infrastructure is set right, and so that it is there in place for multiple other infections which may come up in future. And R naught is 0.8 to 1. So R naught for measles, it is 9. For COVID, it was 2 to 3 to 4. So we have to understand that it is infectious, it can cause, but you see, so the panic and kind of thing it has been created should not be there. Mortality is very less, especially of this type of the current strain. So orthopox viruses, if you see them, they can have many hosts. There are many orthopox viruses like cowpox or monkeypox, they can have many hosts. But like variola, which is a smallpox virus, it has got a restricted host. Camelpox virus, which is another, it has got camel is the only host. So for smallpox and for camel, they are restricted hosts. But there are many hosts for monkey virus. We don't know from where it came, how it came, and how it is going to behave. So it is little bit not clear at this moment. It is an evolving subject. And then there are some cryptic pox viruses like Alaska pox virus. We don't know what is the reservoir, whether it is raccoon, whether it is rodent. So it's not clear. So basically it came from primary host is rodents, squirrels or rats, and then monkeys. And then it came to the by bushmeat hunting, and then it came to the humans. Monkey specific antibody in squirrels was positive in 25%, but while only few monkeys were positive for antibody. So it is mainly the squirrel rodents. From there it came to monkeys and then to humans, and now it is human to human as well. So why they have named it monkeypox, it is still not clear. So whether from squirrel it came or from monkeys, we are still not sure. If you look at this, the current clade is West African clade, and mortality, I have again stressed, it is very low. It is very, very low currently. It is not an African strain at this moment. And in 1978, first case was detected in Nigeria, then 2017, and now it was all over. Since it is a DNA virus, it is a stable virus. So we must keep in mind it is a stable virus, very low mutation rate, and pandemic potential is not there. Endemicity will be there, but there is no pandemic potential for this virus. How it causes a disease, we have to understand. So this brings us to HIV, this brings us to chickenpox, this brings us to even COVID. But the main issue is it is by skin contact that this happens, and at some entry route can be inhalational in the beginning, but mainly it is by close contact, droplets and body fluids. First it goes into the lymph node. So there is a bite or a scratch, and then it goes into the lymph node, which is limited there. From lymph node, it will proliferate to other reticuloendothelial systems, and then the prodrome, classical prodromes, which come is fever and lymphadenopathy. And then after, once this clinical prodrome is over, seeding happens in various organs and skin manifestation happen. So we have to understand this feature of cycle of pathogenesis, how it happens. If we have to give drugs for post-exposure prophylaxis, like HIV we give for post-exposure prophylaxis, we have to give in the very beginning. If some vaccine is to be given to prevent the disease, it has to be given in the very beginning. So that is the concept where the concept of post-exposure prophylaxis comes, or even pre-exposure prophylaxis. So human to human transmission can occur till the lesions are fully healed and fresh layer is formed. Till then, it can happen. People who don't have symptoms, currently it is said that they don't spread the virus. But however, in many patients, they may have rash, and they may have rash first followed by other symptoms. The median incubation period currently is 8.5 days. In US in 2003, this outbreak happened of monkeypox happened in US, and then at that time the classical features were prodromal symptoms, like patient will have fever, localized lymph node swelling, they will have exhaustion, they will have muscle aches, classical prodrome viral symptoms they will have. But the classical feature here is which is a rash, which happens on day 1 to day 4. It may happen after fever, it may happen without fever. But classically, what is said is that it is a deep-seated rash, well-circumscribed lesions. There is central application, and it will go through different stages of macules, papules, vesicles, and then pustules and scabs. You see, it is centrifugal distribution, mainly on the face, palms, and the soles and the periphery. While chickenpox is centripetal, mainly in the trunk, it is more, but however, it is more on the face and the trunk and the limbs. Then, so this is classically what if initially there is a vesicle, then there is a pustule, then umbilicated pustule, then there is ulcerated lesion, and then finally there is a scab which is removed. So if you, how to differential diagnosis? Differential diagnosis is depends on which stage you pick up the lesion. If it is only mucosal lesion on tongue or suppose on tongue, then it is called ananthem, and the differential diagnosis is monkeypox, measles, chickenpox, herpes simplex. But if from anthem, then it goes to macula, and in 1 to 2 days it becomes macule, in 1 to 2 days it becomes papules. So then differential diagnosis, we have to keep both infectious and non-infectious like categories also. So we have to keep that in mind. Then vesicles are formed. Vesicle again take 1 to 2 days, but pustules are there for 5 to 7 days. So we have to keep that So patient will come to you in a late stage. Generally, patient will not come in the prodromal phase. They will come to you in the later stage when rash has come up. So then differential diagnosis, we have to keep these in mind. So genital patients sometimes have presented in this outbreak as genital lesion also. Classical monkeypox genital lesion is painful, and it will again move from macule, papule, vesicle, and then crusting. And however, there can be other differential diagnoses like syphilis and herpes genitalis. We have to keep that in mind as well. So this is classical lesions of like anal lesions of clusters of anal lesions of herpes of monkeypox virus. And then there can be skin lesion on glance also, we can see some lesion, and then there can be skin lesions as well. So the classical outbreak happened in Nigeria. There were some clinical features. Then in US it happened. But current outbreak, is it presenting differently? Is the transmission different? Is it STD? And what are the indications for admission? We will now talk about this. And because what happened was, first in this current outbreak, first patient was from UK. He had traveled to Nigeria. Then he came back to UK with rash, and then he was diagnosed on 6th of May. And then other patients were, they came from Spain, Canada, and US also. Different cases were reported. But however, on genomic analysis, it was West African clade B1. In India, first case was identified 2 months after the first case, which was detected in UK. And this was supposed to be A2 lineage. And in Kerala, we found out this case. And then on 23rd of July, WHO Director General declared it as public health emergency of international concern. It was not a consensus decision, unanimous decision. Many people didn't want it to be declared as emergency, but WHO like DG decided to declare it as public health emergency, so that maybe the concern was that are we prepared to handle such epidemics or outbreaks future, because these epidemics or outbreaks are going to happen. If this today it is monkey virus, tomorrow it might be some other virus. COVID we have already faced. So what is the preparedness? It is now the preparedness part which we have to look at. Probably the positives which we can take from this is that are how much prepared we are as a locally in my hospital, in my country, and globally how prepared we are. Probably that was the message which it gave. So currently it is atypical manifestations. If we look at the various studies which has come in from US, from UK, there it is atypical. Many patients presenting only as proctitis or perianal lesion. So it is not a typical rash which we have described how it will happen. Sometimes prodrome will not happen, only rash will happen. So, and lesions may not be in the same stage. They might be in the different stage of progression. Classically, it is said that lesions of monkeypox will be in the same stage of progression, but they can be in different stages as well. So it is again depending on the immune status of individual, how it behaves. So it is mainly by the close contact. Whether it is STD or not, I'm not sure, but This study in NAGM, it showed that mostly transmission is due to close contact, and 20% of patients did not report sexual contact in last 3 months. And most of these patients were males. All patients were actually males, and 98% were either homosexuals or bisexuals. And 41% were retrovirus positive. So we have to keep in that mind the immune status and how patient is going to behave. So out of these 528, admission in hospital was only 13%. That means rest of all patients were taken care at home. Mainly they were admitted for pain management or some superadded skin infection and or infection control purposes. Otherwise, if you see decreased oral intake, kidney injury, some eye lesion or myocarditis, so complications were rare. Still, so complication which can happen in rarely can happen is, but if you can prevent it, if we manage them better, that secondary infections can happen, then encephalitis or infection in eye is also known. So important is how to diagnose. So I will say that skin lesions, when they have come, it is the best time to diagnose. Early when they have fever and then they have lymph nodes, then there can be other differential diagnosis also. But skin lesion, then they are easy to, we can take the sample from the skin lesion, they're easy to do. So it is basically in the secondary viremia stage, they may be helpful. And the type of test which is required, best test is skin lesion. Otherwise, antibodies can also be done. Currently, antibody testing is not available, but only PCR is available. But antibodies in future, when the antibody test comes, antibody comes positive in 5 to 7 days, and it can remain IgM and IgG both, and then they can also help in supporting the diagnosis. So what is the management? As I said earlier, is it only symptomatic treatment, or is there any specific treatment, or is there any vaccine available? So we have to keep that in mind. Currently, I would say supportive treatment is the only treatment, but we have to be prepared that we have some stockpile of some drugs, some vaccine in future if we have some outbreak here, so that we are not found wanting. So what is the management? Supportive care is the mainstay of treatment. What is the treatment? Treatment of the skin. Treatment of skin lesions, whether it is a skin rash, whether it is a genital ulcer, whether it is oral ulcer, or it is conjunctivitis. Localized treatment of specific organ is required. And most important is hydration. We have to hydrate them well, give them good food, good nutritious food, because protein can also be lost. And then symptom, because these are painful lesions. So we have to take care of pain. We have to take care of itching. We have to take care of nausea, vomiting, and these patients can have headache also. So we should take care of headache and myalgias. So 95% of patients, or I would say 99% of patients will be taken care by the management, which is symptomatic management. But what are the patients where we are, as a tertiary care hospital, I would say, where we have to think where we might have to treat them. So then the whole complication come, because mortality is very less and we have to keep it very less. Then do we have something in our armamentarium so that we can keep it low? So if patient is immunosuppressed, we know what our immunosuppressed conditions are: transplant, hematological malignancies, high dose steroids. And especially if patients have atopic dermatitis, other skin lesions, which are diffuse skin lesions, and pregnant and breastfeeding women, because it can be transmitted to the child. And in current epidemic, only 175 children have been found, and there is no mortality in children. So children particularly, I would say, is again on the safer side, but still we have to take care of them. So apart from supportive care, we have some antivirals and immunoglobulins also. So what are the antivirals which are available, and when to give them, and if at all to be given, and to whom to be given? It is to be given only for a severe disease. What is a severe disease? When there is systemic inflammatory response in the form of sepsis. Once sepsis is there, like low albumin and urea is there, other system involvement is there, then we have to treat them. Or we have a skin lesion. Skin lesions, it has been extrapolated from smallpox. Very severe it is if lesions are more than 250, severe is 100 to 250, and mild is less than 25. Or if the lesions are confluent or hemorrhagic, then we have to think of, and patient is immunosuppressed, probably this is the time when we might have to think of treatment. Otherwise, treatment, it is a mild illness and treatment is only supportive. Two drugs which are available is tecovirimat. Tecovirimat is one drug which has been approved by FDA. It is available in US. It is under very limited circumstances. It can be used with CDC. And the second drug is brincidofovir. Brincidofovir is oral drug, and tecovirimat is both IV and oral drug. So we have IV drug also, we have oral drug also. So in very severe patient, we can combine these two drugs also, and we can use these drugs for post-exposure prophylaxis also. Data will keep on coming, but conceptually we have to understand that these drugs can be used for post-exposure prophylaxis also. Similarly, what happened in HIV? And HIV in 1990s, there was no drug for post-exposure prophylaxis. We had drugs for treatment. So, so it is very important to have some drugs for post-exposure prophylaxis. Tecovirimat, it acts on P37 protein inhibition. It doesn't cause encapsulation of virus. So that is why virus dies. So that is where it acts. Cidofovir, it is a viral DNA polymerase inhibitor. It inhibits the virus factory. So that is where it acts. So we have these two drugs. But I would say the best drug is tecovirimat in current circumstances. How it has been FDA approved? It has been FDA approved for smallpox by animal rule. What is animal rule? Animal rule is, no, we can't create smallpox in human population. So so drugs which are useful in animals, they are used, and then the pharmacokinetics are used in the humans. And if there is safety data, then by animal rule, these drugs can be used. That is how tecovirimat has been approved. It is both IV and oral. In animals, in primates, non-human primates, when it was used, all animals survived, and there was dramatic reduction in skin lesions and oropharyngeal shedding and blood viral. Other drug is brincidofovir. I would say it can cause fetal harm. It has got hematological toxicity and renal toxicity. And so I would say tecovirimat is a simple drug. It may be useful in the current circumstances, but this drug can, no fetal, not so fetal, it might not be so harmful in pregnancy. So that is better drug, but brincidofovir, I think is more toxic. The other thing is vaccinia immunoglobulin. Vaccinia immunoglobulin is only available with CDC, and it has been used in severe patients where there are complications. So this is another drug in our armamentarium in acute conditions. It can be used. So how much treatment has been used in these patients? The study by NAGM showed that 95% patients required only supportive treatment. Specific treatment was required only in 5% of patients. And they used topical cidofovir or IV in less than 2%. Tecovirimat was used in 2%. So it was used in only occasional patient, and vaccinia immunoglobulin in less than 1%. Outcome data is still not available. It will come in future, but still currently it's not available. So I would say supportive treatment, but except in few circumstances, we have these drugs. So we should have some stockpiling in case it is required to be used in a specific group of patients. Otherwise, if patients are stable, they can be home isolated, they can be treated at home. Routine infection control measures which are used can be used at home. Everybody now knows how COVID patients are taken care of. So they are similar ways it has to be used. And now we have to watch for contact. For contact, or even for patient, 21 days is the period when isolation has to be there. They should not donate blood, tissue, etc. And if contacts are asymptomatic, they can continue with their routine activities. If there is fever and rash, they have to self-isolate it and get tested. And if there is no fever or rash, but there is lymph node or chills which are persistent, then we have to think of alternate etiology also. So it is mainly it is clinical suspicion, mainly it is isolation, that's it. And symptomatic treatment, this is what is required. So what about vaccines? So monkeypox vaccines, we have 3 types of smallpox vaccine, and they have been monkeypox and smallpox, they are they have been extrapolated from one study on basis of observational data. The Dryvax, which was the first generation smallpox vaccine, it gave the effectiveness of 85% to prevent monkeypox. That is how whole data has been extrapolated. There are two types of vaccine. One is Genios, and second is ACAM 2000. ACAM 2000 is a replication competent vaccine. Replication competent vaccine means it can cause acute vaccinia. It can cause acute infection. In immunosuppressed patient, it can cause take occurs. Take is it can cause infection at other sites. It can cause serious adverse reaction. It can cause myocarditis and other things. So it has got its own limitations, and they should not be given to patients with acute immunodeficiency, atopic dermatitis, and pregnancy, and infants less than 12 years. Gyneos, again, it is no human data is available, but it has been postulated that it will be effective. It is replication deficient. It will not cause the side effects which is caused by ACAM 2000 because it is replication competent, and Gyneos is replication incompetent. It is the current vaccine which has been approved by FDA in 2-3 days back only. However, the problem is you require 2 doses, and immune response takes 6 weeks. For ACAM 2000, you require single dose. It is given intradermally. In our childhood, when we were given this vaccine of smallpox, it was given intradermally and multiple injections were given. So it was painful. Similarly, percutaneously, it is given ACAM vaccine, but this Genios is a subcutaneous vaccine like other vaccines. Immune response and single dose is required for ACAM, but I would say Genios is a better vaccine. It may be helpful. And what is the use of these vaccines? The use of this vaccine is in post-exposure prophylaxis, high risk and intermediate high risk exposure. So if we have to, we see the cycle of pathogenesis. It goes there, it goes in, virus is there, it goes in the lymph nodes, it gets there, and then it goes to different organs. So as early as we give, it may be useful, but for post-exposure prophylaxis, antiviral have also roles, so they can also be used. And this vaccine, if it is given late from 4 to 14 days, it may not cause severe symptoms, but it will not prevent the disease, but symptoms will be reduced. So currently vaccination is not recommended, mass vaccination is not recommended, but this is one thing which we should have in our armamentarium, especially patients or healthcare workers who get exposed, and it might be helpful for them. For pre-exposure prophylaxis, again for smallpox, it has been recommended, especially for laboratory individuals and designated response teams who take care of these patients and healthcare personnel who give these vaccines. And then booster has to be given for ACAM every 3 years. For Genios, it is every 2 years. So what is the take-home message? Is it HIV? Is it chickenpox? Highly virulent? It is not so virulent. It is through close contact. And largest outbreak has happened in non-endemic countries, but mortality is very low. WHO like DG declared it public health emergency on 23rd. It was not a unanimous decision, but probably they thought it is time to prepare healthcare services for local, regional, and global response. So it is our time now to be prepared for not for monkeypox, but for all type of infections which will come up in future. It is the data says it is more in MSM, but it is due to more due to close contact. But we have to avoid stigma and discrimination, which has happened in HIV and in other conditions. So we have to avoid this at any cost. We have to keep in mind it is not always a typical rash. It can be atypical rash also, like primary genital lesion or different stages presenting simultaneously, and maybe no prodrome symptoms, or it is missed prodrome symptoms missed. And I would say main treatment is supportive, but we should have some drugs in our arms. We should have stockpile of some drugs. Thank you. Thank you very much.
Thank you, Dr. Vic, for a very comprehensive coverage of the clinical presentation and management as far as monkeypox is concerned. And I think it's very important for us to remember, and I think the key issues here are to highlight the fact that this is a mild self-limiting illness. I think it's very important for us to understand that. And this is basically the West African clade rather than the Congo Basin clade. And the West African clade, which also caused the outbreak in Nigeria in 2017, is associated with a very low mortality. So it's important for us to understand these two important issues when we talk of the management. It's a mild self-limiting illness, very low mortality, and therefore one need not have a panic situation. It causes the classical symptoms which we discussed even on day one, and like we discussed on day one, it is not classically a sexually transmitted disease, and we should not label it as an STD. We need more data. The paper in NEGM did tend to show that it was predominantly in men having sex with men, but I don't think that is something that is correct when we start looking at it, when we get more and more data. Uh, you can also at times have a flu-like syndrome, and that is something to keep in mind because the virus also proliferates in the nasopharynx and the upper respiratory tract. But the main symptoms continue to be fever, body aches, myalgias to begin with, followed by the rash, which happens a little later than what we see as far as chickenpox is concerned. As Dr. Vig rightly mentioned, the management is predominantly supportive, and that is what the Ministry of Health and Family Welfare guidelines also mention, that you have to have supportive management strategies. The role of the two drugs that have mentioned, tecovirimat and brincidovir, is important. Both of them got an approval for under the animal rule, which was basically based on animal studies, and it was not possible to do human studies. Even you couldn't do a human challenge study because of ethical reasons. But these were approved basically for smallpox, and it has been extrapolated for other orthopox virus, including monkeypox. They should be effective, and that is something that we need to keep in mind. But unfortunately, bulk of the stock, or I'll say the entire stock, is with the CDC, and it is a drug which is not freely available, and therefore that is always going to be a challenge for us to have that drug available for us. As far as vaccines are concerned, again, two vaccines which are the new generation vaccine. Dryvax was the initial smallpox vaccine which was used and which in the 80s showed that it had 85% efficacy against monkeypox also when Dryvax was given as a vaccination for smallpox. Studies in Africa showed that those who got this vaccine had 85% protection against monkeypox. However, Dryvax was moved out by the company. The company stopped manufacturing Dryvax and they started manufacturing ACAM 2000. And as was mentioned by Dr. Vig, that this vaccine has its own issues of side effects because it's a replicating vaccine. The Genos vaccine, which is basically from Vaccinia Encara and has other names depending on which part of the world you are getting it available, is the one which is recommended currently both from the smallpox point of view and monkeypox point of view. Again, vaccine is not available. There is no need for a vaccination program. In my mind, the cases are not large enough. There has been discussion of ring vaccination, that you vaccinate those who are in close contact so as to protect them. But I don't think even ring vaccination currently is something that we need to look at. And therefore, the vaccination program currently is something that should be kept in mind, but it's not something that we need to look at seriously as of now. Yes, there are pre-exposure and post-exposure uh, prophylaxis vaccination which is given. Pre-exposure, as was mentioned, the ACIP mentioned it for those who are dealing with orthopox viruses, either in the lab or as a part of research or in terms of patient care, but again, really not required. The point that I'm trying to highlight is it's always good to have a knowledge of all of this. The treatment currently is mainly supportive, and that is what we need to highlight on supportive care, good hydration, making sure that the patient gets good ORS, symptomatic treatment, and it's a mild self-limiting illness, and we should not really be worried too much about it. Uh, Current recommendation as far as sexual activity is concerned is that in a positive patient, you should avoid sexual activity for at least 8 weeks. But like we discussed yesterday, we need more data in terms of the virus in the semen and how does it transmit in terms of sexual activity. So this is the point that I wanted to highlight predominantly, that it's a mild illness, very low mortality, self-limiting, and we just need to focus on supportive care and isolation of the patient, as was also mentioned. We'll discuss this, of course, in more detail tomorrow. So I'll if there are any questions in the chat box, we can take them.
So we have some questions that have come in the Q&A box, so maybe we could start with those. So the first question here is the availability in India of topical Cidofovir. Is it available, and what is the trade name? Or how do we get it?
It's not available at this moment.
So
it can be procured. It's not officially available.
Cidofovir is not officially available. It is also a toxic drug. It has actually the FDA approval for Cidofovir is for CMV retinitis in HIV positive patients and as a topical application. It is otherwise not easily available and not even recommended for other use. And that's why this drug is not freely available. Kaushal would like to add anything else to that?
Yes. Nothing more.
Right, sir. So the other question that we have is more about epidemiology rather than about treatment. And it says that is there any reason why we're getting a lot of viral disease outbreaks in the recent time? So if it's COVID, monkeypox, hand, foot, mouth disease, is there any postulation as to why we're seeing so many viruses?
Yeah, so there is a postulation. I discussed that I think 2 days ago that we are seeing, and I said that this century is a century of outbreaks. So the last 22 years, we've had outbreaks starting from SARS, MERS, Zika, H1N1, outbreaks of Ebola in different parts of the country. And we've also had this fear of H5N1, which is avian influenza. And that is related to multiple factors, which I discussed that day. One was that now we are traveling, the world has become a global village, and you can travel with your viral infection quickly from one part to the other. And infections which are thought to be localized only to Africa are traveling all over. Ebola was seen predominantly in Africa, yet we had cases even in the US and in other parts of the world. So we are becoming a global village, and the incubation period is within the incubation period, if you travel, you can carry the infection to that area. Classical example, of course, is SARS in 2003, traveled all the way from Hong Kong to Canada and led to a huge outbreak in Canada. Also, the important thing to remember is that now there is a lot of encroachment happening. We are moving more and more into areas which are predominantly of let's say, animals, and therefore there is a jump of viruses from animals to humans. All the outbreaks that we've seen in the last 22 years are zoonotic in origin. So they have jumped from animals to humans, and then they have developed and evolved to have good human to human spread. So encroachment, crowding, closer interaction of animals with humans, and of course travel are all important factors. And that is why there's this whole concept of now looking at health as one health rather than only looking as health of humans, but looking as health of animals, plants, the planet, and humans in a holistic manner. And that is why the whole concept of one health is being promoted.
So as a follow-up possibly to that question is a question that has just popped up. So can we possibly prevent all this if we create a ban on contact with animals universally?
It's a critical question. I don't think it's possible now. And it has to have a global surveillance. If you think, what can we do? There needs to be a global surveillance so that we are able to prevent infections. We all know that we had COVID for quite some time, limited only to China, but we could not prevent it from spreading from China to Italy and then to the US. So it's going to be very difficult. But if we have a very robust international surveillance program, and that surveillance program is followed by good restrictions so that we are able to contain the spread, and this can be done at a national level, it can be done at an international level, then we may be able to prevent spread. But it's going to be very difficult because, like I said, the virus will travel with you while you're in the incubation period. You're asymptomatic. So you will not have any symptoms during that time, and none of the tests will pick it up. So it's going to be very difficult to be able to stop this. And the reason I'm mentioning this is that only 2 days ago, we've had a new virus reported from China. And that is also a cause of concern that how is that going to behave as we move ahead. So like I said, more and more outbreaks in the near future.
So, so that is why it is important, because our diagnostics are improving. Our panic reactions are increasing. So this is probably how, that is why WHO didn't want to be faulted this time they declared it for international emergency for international concern. Probably we act and make our act right. Because still one health concept is 20 years old concept. What have we done today for that one health concept? So that is where we have to think, we have to introspect, and then we can move forward. Because you see, in many countries, One Health is the prime thing. And where we are, we have to understand this. I can't say more than this, but we have to introspect and see where we are today in One Health.
Okay, so I just wanted to, before Rajiv comes in, if there are any members on the panel who would like to give their comments or would like to say anything, just either raise your hand or put your video on, and then we'll also ask you for your comments or your experience as far as monkeypox or any other issue that you would want to discuss. Over to you, Rajiv.
Right, so I'd just like to remind the attendees that they will need to put their questions in the Q&A box or the chat box. We can't bring them on live, so they shouldn't be raising their hands and they should be putting their questions in the chat box or in the Q&A box. So one of the questions we actually had yesterday, but we didn't take up, and I think we could bring it up today, is that we seem to be in the midst of a rise of COVID cases as well. And there seems to be a reasonable amount of overlap maybe of early symptoms between COVID and monkeypox. So what should be tested and who should be tested? Test for COVID, test for monkeypox, or wait and watch?
So COVID is much more prevalent than monkeypox, and COVID does not cause a rash or the usual lymphadenopathy that you see as far as monkeypox is concerned. So I think if you have an upper respiratory catarrh and features like that, and you have fever, body aches, COVID-19 test would be more important than doing a monkeypox test. But I would really stress, and maybe I can use this platform to say that we need to get more and more people to come forward, get themselves tested if they have symptoms, and also report it. I personally feel that we are going through another wave, but this is an undercurrent of a wave because people are not coming forward and getting themselves tested. Many of them are using the rapid antigen test at home and then not reporting it. So the number of cases are probably much more than what we are getting on the portal. And therefore, it's important that we be vigilant, follow good infection control practices like wearing your mask and hand washing, and at the same time be careful, because if you have a large number of cases, you will have some admissions which will also go up. Although current cases are mainly mild, but in absolute number, even if you say it's only 1%, that number becomes significant. So I think we need to really have good infection control practices like we were following in the past.
So it is epidemiological concept. Since today COVID is most common, it is only COVID. We have to think of that. Monkeypox is very rare at this moment, but it is mainly COVID, and main thing is isolation. So person needs to isolate and get tested.
Yeah, Dr. Kaushal wanted to make a comment.
Yeah, I think we discussed this yesterday also, that every fever and rash is not monkeypox. And the rash of COVID is very different from the rash of monkeypox. The monkeypox has similarity with other viral rashes that we discussed as differential diagnosis. But remember that fever and rash is not always monkeypox. The emphasis that is why is being placed that the rash is different in monkeypox and in the COVID patients. That appears later, and this is pretty early.
It is not pustules.
It's very different. It's very different.
And okay.
Then continuing with that question about rash, there's a question which talks about scarring. Do we expect scarring after the infection or the rash in monkeypox? And do we need to get vaccinated after a monkeypox infection?
Dr. Kaushal.
Yeah, scarring, the lesions are deeper. They are indurated. They form scab. So when they heal, they leave behind scar, and then scars also improve over the period of time. But some degree of, say, visibility of these scars may persist.
So scarring will persist, but again, that stigma and discrimination we have to handle.
And do you need to be vaccinated once you got the disease? I think.
No. So there are some studies in which people who were vaccinated for smallpox, even long-term protection was also there. So once you are infected, you are same with chickenpox, you are protected.
So you have protection if you have the disease, but one of the reasons that those people who have got a smallpox vaccination, and this is one of the other reasons that is put forward for increase in cases of monkeypox, is the discontinuation of the smallpox vaccination. When smallpox vaccination was being done, there was also protection against monkeypox, and therefore those who have been vaccinated against smallpox, it's argued that they have some protection also against monkeypox.
Continuing with that stigma issue, there's a piece of information that's been provided by Dr. Vijay Lakshmi Sahu, who states that out of the 4 confirmed patients at MAMC and Loknayak Hospital, the onset of lesions were from the genitalia, but there was no travel history and all patients denied any MSM contact. So that would be an interesting aspect of realizing that it's not an STI.
So it must be already there now. Since it has got so much attention, we have to be suspicious, and atypical lesions are very common in these patients. We have to keep that in mind. It is not always a typical classic rash. It can be at atypical sites also.
So I think there is one, I don't know, Dr. Kaushal can comment on that, but there is one opinion which is going around that probably monkeypox was there even in the past, and it's been there for some time, because one of the lineages reported is an older lineage, and therefore it may not be of recent origin, but it was never tested. And now with patients coming with these symptoms and testing being done, we're picking it up, and that is why the travel history is not there. What would you like to say?
Yeah, in fact, last time also we had talked about that every genital rash is not monkeypox. So the genital rash, if it is there, we should need to carefully look at as to what kind of genital rash is this and how does it behave. And it's possible that yes, some patients who have got monkeypox, they have no travel history, but they have come in contact with the other people who probably had a travel history. So it was probably the asymptomatic, say, transmission of infection from the people that they got exposed to. And that's how it has developed. And some people developing only genital lesions, I think we will have to be careful labeling them that, yes, this is a sexually transmitted infection that we have talked earlier also. And majority of these patients have been immunocompromised and having multiple, say, other infections also. In one of the studies that I was recently reviewing, the semen has been found to be having 29, say, viral DNAs. So we don't know if this is probably has been going on, and now it is making more, say, coming to attention.
Another piece of information, this is from Dr. Ranjana Beniwal, who says that we've had 2 patients on cancer chemotherapy who have vesiculobullous lesions on the extremities, but haven't yet been confirmed as monkeypox, but they're probably suspecting that as well.
Yeah, but then like we said, you need to have a definite confirmation, because all lesions are not monkeypox, and people who are on chemotherapy are also prone to other infections
and other vesiculobullous diseases.
And other vesiculobullous diseases.
So the diagnosis is so broad, so proper skin consultation and diagnosis from that is most important. It can be infectious, it can be non-infection, it can be drug-induced.
Yeah.
So we have to keep so many things in mind, and labeling any rash is not right, and panicking was also not right because it is not so infective. We have to take infection precautions, which we take for all patients. Chickenpox is 9 times more infection. R naught for chickenpox is 9. R naught for monkeypox is 0.8. So we have to think that way, and we have to keep that in mind, and we have to nip the evil in the bud, except that we should have some drugs in our armamentarium for post-exposure prophylaxis.
So we've reached the end of the questions that we have for today. It seems most of the issues have been clarified over the last 3 webinars. So if there's any summing up that you would like to do, or any of the panelists would like to speak.
Any of the panelists would like to say anything? I think one.
Can I make a comment?
Yes, please come in. Please come in.
I'm Dr. Anuja. I'm from Trivandrum. I'm a dermatologist. I was actually there on the panel yesterday also, and I made a few comments yesterday.
Yes.
I would like to make 1 or 2 comments. That is, one is we have sensitized everybody, and everybody is now almost on a panic mode. The thing is, we have had out of the 5 cases in Kerala, 1 had presented as, the atypical presentation is high. We were talking about that previously. So 1 had presented as a carbuncle on the neck and with an inguinal swelling. So actually this patient presented to the surgeon. Usually most of these cases present either to the dermatologist or to the physician. And in this particular case, I think that was the first time that the patient presented to a surgeon because he had an inguinal swelling. Apparently he turned out to be monkeypox positive. He was tested and he was found to be positive. But the problem now is because of these atypical presentations, everybody is going on a panic mode. And everybody wants their patients to be tested. Any skin lesion, they refer to the dermatologist to rule out a monkeypox. In fact, out of the 7 or 8 cases that we had in Trivandrum, which was referred to us to roll out monkeypox, only the very first case, that is the first case that we have in India, he turned out to be positive. All the other 7 cases, 3 were chickenpox, 1 was HFMD, 1 was confirmed gingival stomatitis, and 1 as yet undiagnosed. So I think we doctors are a little bit on a panic mode, and that has to be stressed out that not all cases are monkeypox, even though atypical presentations are very high with this present clade. The second thing I would like to say is in our case, because that was a very first case, everybody was panicking, and even the patient was very upset. So his case, he was a very mild case as per the criteria. He had only less than 20 lesions. So he was classified as the mild group, but he didn't have any symptom, systemic involvement. But his main problem was he was very upset, and he needed a lot of psychiatric consultations and counselings. So along with the symptomatic treatment and supportive treatment that we give, I think all our patients need a little bit of psychological counseling and treatment, which our patient was getting almost every day. And he has gone home happily. Now he's in a very happy mode. So I just wanted to make these 2 comments. Thank you.
Thank you very much. So I think very important points, and I think it's very important for us to keep in mind that there is a stigma which is there, which leads to patients having some sort of, let's say, psychological effect on them, and they need counseling. We saw that in COVID also, and especially when you have a new viral outbreak, when there is this whole issue of sexually transmission and some new virus, the stigma does happen, and there is a need for having that counseling. I also think it's very important, and this is what we've been highlighting for the last 2-3 days, that there is no need to panic. It's still a very mild, self-limiting illness, and I would still call it a rare disease. So you don't need to really jump that every case that you see has got monkeypox, and it's an atypical presentation, and therefore every case should be investigated. That reassurance also needs to be given, and I think it's our responsibility to do that. Both from the dermatology point of view, from all physicians' point of view, that is something that is another important issue that I think you've raised, and it's very important that we keep that in mind. Dr. Naveet, you wanted to say something, and Dr.
So
Kaushal.
Dr. George, very important point, how to take care of stigma and discrimination.
Yes, sir.
So how to take care of that is a question, and we can handle it only if, as doctors, we are confident that this is not a disease to be panicked. The only treatment is isolation. The only treatment.
Yes, we are trying. We are trying to disseminate that information. It's very mild and usually self-limited.
So first doctors have to understand this. Then public messaging has to be like this, that they should not panic, and because panic starts from everywhere. And then community education should be there, and then we should have facilities for patients who are monkeypox positive to be isolated.
Yeah, I think Anuja, it is our responsibility.
Yes.
To create awareness and tell the people, doctors including, the problem occurs when there is a lesion in the genital area, even if it is very innocuous. And if something which has happened in the genital area, people are excessively concerned, both the males and females. Why it has been there, why it is there, what is this? Is this a sexually transmitted infection? Is it monkeypox? Now, since the monkeypox is going on in the, say,
so that has become
a major concern for people, that yes, any rash, is this monkeypox in the genital area or elsewhere on the body? Even the people are coming with the insect bites, and they are wanting that, Doctor, is this monkeypox? Or any rash which is appearing on the hands and feet, even if it is, say, because of some kind of allergic reaction or some kind of infection or maybe some bites. And if sometimes even if they have the feeling of feverishness, it's not fever.
Yeah,
they have a psychological impact that yes, the effect that yes, the rash is there. I think I also have fever. So is this monkeypox? That's not the case. I think we need to be knowing this and we sensitize the doctors, healthcare workers, and then this message go to the community that yes, Every rash is not monkeypox, and
Correct.
rash associated with fever is also not monkeypox. Genital lesions are always matter of concern. We need to educate them that every genital lesion is not a matter of concern. There are several diseases which occur that you know they are non-infectious, but they can still remain confined to the genital area. And any lesion occurring on the body, again, dermatologists need to be consulted. They need to be shown that yes, this is truly a matter of concern or a reason which we should be worrying about, and trying to tell them that yes.
Yeah, I think that is an important message.
And it's self-limiting disease. Only 2%
Yes.
people require intervention. More than 95% they will become all right on their own. Quite unlike several other serious illnesses.
So I think that is very important. It's a mild self-limiting disease. Finally, Dr. Anant, what would you say is the complications? What are the complications that could occur? Because I think that's also important to highlight when you're discussing clinical manifestation. What complications can happen, which are very rare in as far as monkeypox are concerned?
Yeah, so complications are rare. Some complications, usually the risk people, high risk people would be the ones who might develop some complications, which was already enumerated, the immunocompromised group, the extremes of age, those who are on cancer, chemotherapy, etc. The few complications which have been reported so far in the limited literature are like, for example, superadded pneumonias, superadded infection on the skin lesions, rarely some corneal problems leading to some visual impairments. There may be infection leading to sepsis or septicemia, and rarely, I think, a couple of cases of encephalitis related manifestations have been reported. So these are all extremely rare, and they all occur only in some specific high risk subgroup of people. And but I think that needs to be just kept in mind for those who are actually treating them in an area of clusters.
But I think the important issue is to remember that these are very, very rare. It is still a self-limiting mild illness with a very low mortality, and we should not have stigmatization. Treatment is predominantly supportive, and that is what we need to focus on. I think we can. Any other comments? Rajiv, over to you, and then maybe if there's anyone from the ministry who would like to conclude.
We have no other questions, sir. So we'll meet again next Wednesday and we'll discuss a little bit about prevention. And that's all that we have for today, sir. You can hand it over to the ministry for now.
Thank you, sir. Thank you for the wonderful session that Professor Vig has taken. It was really very eye-opening for everyone who has just participated. And we had taken the message that this is a mild disease, rare disease, and where we need not be panicking ourselves. It was really nice to hear from Dr. George also, who had seen the first case of this country. And I'd like to thank especially to Professor Randeep Guleria, Director of All India Institute of Medical Sciences, Professor Kaushal Verma, Professor Vig, Professor Anant, Mohan, and Dr. Nishchal for this wonderful session that has been conducted through All India Institute of Medical Sciences. Thank you, sir.
Thank you very much. And we'll meet on the 17th to discuss prevention and infection control practices as part of the last webinar in this series. And like I said, if there anything else that you would want that we should discuss or bring up, you can bring that up to the notice of the ministry. So thank you very much and all the best.
Thank you.
Thank you.